Hello everyone. Today we are going to discuss about a new chapter that is broad spectrum antibiotics. What are broad spectrum antibiotics? The name given as they contrasted to the existing antibiotics at that time, that is around 1944 and 1950. So at that time we have mainly penicillins and streptomycin which are available, and these are going to differ. The newer broad-spectrum antibiotics are going to be orally effective and having wider spectrum of activity. So, broad-spectrum antibiotics, they have activity against aerobic, anaerobic, gram-positive, gram-negative organisms, rickettsia, mycoplasma, and chlamydia, and also some parasites. So that's why they named as broad spectrum antibiotics. So this broad spectrum antibiotics includes mainly two groups. The first one is tetracyclines, the second one is chloramphenical. So today we are going to discuss and learn about tetracyclines and chloramphenical. So the first one is tetracyclines. So the name itself is going to tell you tetra. Tetra means four. Here in this picture you can see one, two, three, four. Four rings are there in the structure. That's why these are called as tetracyclines. So when it comes to the history, you all know this guy is a great scientist, Pragada Subbarao. So he is the one. It belongs to Andhra Pradesh, and he is the one. Is the man behind development of tetracyclines. So tetracyclines is a class of antibiotics. As I told you, they are nucleus of four cyclic rings, and these are obtained from soil actinomycetes. So the first one is called as chlortetracycline, which is in 1948. They discovered in 1948 under the name iromycin. So iromycin or chlortetracycline, both are same. So all tetracyclines are slightly bitter, solid, and slightly water soluble, but their hydrochlorides are more soluble. Right? When it comes to the classification, there are short acting, intermediate acting, long acting, and a newer tetracycline that is called glycyl cyclines. So in short acting, we have tetracycline, chlortetracycline, and oxytetracycline. Intermediate acting, demiclocycline and metacycline. Long acting, doxycycline and minocycline. Just now I told you the newer tetracycline group that is called as glycyl cycline. Only one drug is there, that is tigecycline. So the major difference between the older and newer tetracyclines. So the older one having low potency, the newer drug having higher potency, a newer one will having longer acting, and newer drugs are going to absorb completely, almost completely from the stomach, and they are going to excrete it to the liver, and will have low diarrheal incidence but high phototoxicity. So there will be multiple advantages of newer tetracyclines. Coming to the mechanism of action, you all know in previous class regarding penicillin, I told most of the antibacterial drugs having two different type of mechanism of action. Any one of the mechanism of action, that means either it may be going to inhibit the cell wall synthesis or maybe the inhibition of protein synthesis. Here, the tetracyclines are going to inhibit the protein synthesis. So, what happens in case of prokaryocytes? Prokaryocytes, we have 70S ribosome that contains two subunits. One is 30S and the other one is 50S. Here we have a mnemonic that is called buy at 30 and sell at 50. Here buy at A for aminoglycosides and T for tetracycline. That means tetracyclines are going to act on 30th ribosome subunit and it is going to inhibit the protein synthesis. How it is going to inhibit the protein synthesis? Here comes to the tetracyclines, they are mainly bacteriostatic drugs. Most of the antibiotics either may be bacteriostatic or bactericidal. Bactericidal means they are going to kill the bacteria. Bacteriostatic drugs mean they are going to inhibit the replication and inhibit the growth of the bacteria. And I already told you these tetracyclines are going to inhibit the protein synthesis. By binding to 30S subunit of ribosome in susceptible organism, then attachment of amino acyl tRNA to the acceptor site of mRNA ribosome complex is interfere. That means that means tetracyclines are going to attach to the A site, acceptor site of 30th ribosome. I will tell you in the next slide regarding pictures and all. Here you can see the prokaryocytic ribosome contains 50S and 30S subunits. And here mainly there are two sites. A site or amino acyl tRNA site. It is also called as acceptor site. And P site that is called as peptidyl site. And comes to the mechanism of action of tetracycline, they are going to bind to A site where the amino acyl tRNA is going to bind. So by blocking the binding of amino acyl tRNA to 30S ribosome, tetracyclines are going to interfere the protein synthesis and these are bacteriostatic drugs. Here again you see as I told you we have two sites. A site that is called also called as acceptor site, the other one P site. P site here the tetracycline will come and attack here A site and prevent the binding of amino acyl tRNA to A site. That is going to prevent protein synthesis. And coming to the one of the type of classification of antibacterial drugs is bacteriostatic drugs and bactericidal drugs. So what are these bacteriostatic and bactericidal? I already told you bactericidal are going to kill the bacteria and bacteriostatic drugs are going to inhibit the replication and growth of the bacteria. And comes to the today our topic tetracycline and chloramphenicol both are bacteriostatic drugs. Here again there is a mnemonic called as select C. So this select C, S for sulfonamide, E for erythromycin, linezolid, ethambutol, chloramphenicol, tetracycline and clindamycin. These are all bacteriostatic drugs. And all other, you all know, bactericidal, penicillin, cephalosporin, quinolones, metronidazole, rifampicin and multiple drugs. Right? So coming to the antimicrobial spectrum. As I told you, they are going to practically inhibit all the types of pathogenic microorganisms except fungi and virus. Hence the name broad spectrum antibiotic. But we all know the indiscriminate use of any antibiotic will finally lead to resistance. So that's why now so many organisms has developed resistance to the older tetracyclines. Till the newer tetracyclines are commonly used for following organisms: all gram positive and gram negative bacteria, all other spirochetes, mycoplasma, rickettsia, everything, chlamydia, borrelia, yersinia, vibrio, brucella. By knowing the spectrum of any antibiotic, we can easily write the uses of antibiotic, right? So for example, if you see chlamydia is going to cause trachoma, is going to cause urethritis. So the uses are trachoma and urethritis. So like that, rickettsia is going to cause so many fever, rickettsial fever, mountain fever, multiple things. So like that, we can easily write the uses by knowing the spectrum of any individual antibiotic. Of course, coming to the resistance is going to develop in a graded manner. Here, what happens when you are not going to having any interest to come to a class? So, for example, you imagine you are going to pump it out. That means you are going to pump out the teacher, right? Just for imagination, not reality. It's not going to occur. So the tetracycline concentrating mechanism become less efficient. Our bacteria acquires capacity to pump it out. That means if you enter to the classroom, you are going to pump it out. So like that, the plasmid mediated synthesis of a protection protein which protects the ribosomal binding site from tetracycline. Here they will having a cover. They forms a protection cover. For example, if I am taking the class, you are not interested, you are going to close your ear. So whenever you are going to close your ears, that means complete protection. So you are not going to hear. The same thing, the same manner is a plasmid mediated synthesis of protection protein, which is going to protect the ribosomal binding site from tetracycline. So coming to the pharmacokinetics, older tetracyclines are incompletely absorbed through GIT. So better to take an empty stomach. Doxycycline and minocycline are completely absorbed irrespective of food. The main important is doxycycline. Doxycycline is one of the widely used tetracycline now. Tetracycline having chelating property. What is chelation? They are going to form insoluble and unabsorbable complexes with calcium and other metals. So what is this meaning? That means you are not supposed to take tetracycline with milk. So milk will contain calcium, so they are going to form insoluble complexes. And tetracyclines are not going to absorb. So there is no action. So that's the importance of chelating property. As I just now told you now about milk and iron preparation and non-synthetic antacids. That's what gelusil and all diazine and all those. So they are going to reduce the absorption of tetracyclines. So and are widely distributed in our body, concentrate in liver and binds to the various tissues, connective tissues like bone, teeth. So most tetracyclines are primarily excreted in the urine by glomerular filtration. So dose has to be reduced in renal failure. So in case of renal failure patient, better to avoid tetracycline, go for any other alternative. We have only one exemption, that is doxycycline. Doxycycline is going to excreted through GIT, that means stool. So there won't be any problem using in case of renal failure patient. So administration of oral capsules in the doses is the dosage form, of course, capsules. So the capsule should be taken half an hour before or 2 hours after the food. And of course, all the liquid oral preparations for pediatric use are banned in India. These drugs are contraindicated in children. Like quinolone, these drugs also better not to use. Go for a better drug in children. So you are not supposed to give, not recommended to give by intramuscular route because these are painful. So coming to the adverse effects of the tetracycline, they are having irritant property. That means they causes gastric irritation, which leads to epigastric pain, nausea, vomiting, and diarrhea. Irritant diarrhea should be distinguished from the due to superinfection. I will tell you what is superinfection, why tetracyclines are going to be one of the most common reasons for developing superinfection. And what I know of phasia and esophageal ulceration. These has occurred by the release of material from the capsule in the esophagus itself during swallowing, especially with doxycycline. Intramuscular injections, as I told you, these are more painful. Very rarely, intravenous injections can cause thrombophlebitis. Coming to the organ toxicity, they are going to cause liver damage, fatty infiltration of liver, and jaundice can occur. Oxytetracycline and tetracyclines are safer, and tetracyclines having high risk and are not supposed to use in pregnant women. One of the reasons is they can cause acute hepatic necrosis, which can be fatal. And coming to the kidney damage, the risk only there when the presence of existing kidney, all tetracyclines except doxycycline. As I told you now, doxycycline is not going to eliminate from the kidney. So that's why it is a safer one in case of renal failure. And one more is that a reversible Fanconi syndrome like condition which is produced by outdated tetracyclines, which are caused by degraded products. AP-tetracycline, anhydrotetracycline, AP-anhydrotetracycline, which damage proximal tubule. That means to renal damage and anemia and all those. And coming to the phototoxicity. Phototoxicity is sunburn-like or other severe skin reactions on exposed part in some individuals. The higher incidence of phototoxicity is more with demiclocycline and doxycycline. And rarely destruction of the nails also occur. And very important, as I already told you about their chelating property, they are going to form calcium tetracycline deposits in developing teeth and bone. That's why, as I told you, these are contraindicated in pregnancy and contraindicated in children. Given in the mid pregnancy to fifth month of extrauterine life, the deciduous teeth are going to affect, will cause brown discoloration, ill-formed teeth, which are more susceptible to the caries. Tetracycline given between 3 months to 6 years of age, which are going to affect the crown of permanent anterior dentition. You are not supposed to use tetracyclines in children, especially less than 8 to 10 years. So here you can see the brownish coloration. So given during late pregnancy, childhood, they can cause temporary suppression of bone growth also. So as I told you, mid-pregnancy to fifth month of postnatal life, the deciduous tooth is going to affect brown discoloration. 2 months to 5 years of age, permanent teeth is going to affect pigmentation and discoloration. Pregnancy and childhood, the depression of bone growth, depressed bone growth. So anti-anabolic effect, tetracycline reduce protein synthesis, have an overall catabolic effect. They induce negative nitrogen balance, can increase blood urea, and very rarely increase intracranial tension is noted in some infants. When it comes to the diabetes insipidus, demiclocycline antagonizes ADH action and reduces the urine concentration ability of the kidney. The use. So, right, in case of diabetes insipidus, demiclocycline can be used because it reduces the urine concentrating ability. So, coming to the next slide. Vestibular toxicity can be caused by minocycline, which is going to cause ataxia, vertigo, and nystagmus. Hypersensitivity, infrequent with tetracycline, can cause skin rashes, urticaria, glossitis, pruritus ani, valvulae, angioedema, and anaphylaxis are very rare. Superinfection. So these are going to cause and are frequently responsible for superinfection because they cause more marked suppression of resident flora. So we all know we have so many helpful bacteria in our GIT. So these tetracyclines are going to kill those bacteria, marked suppression of resident flora. So though mouth, skin, vagina may be involved, intestinal superinfection by Candida albicans is more prominent. So the overall thrush or intestinal candidiasis, which is a fungi, right, is the most common superinfection which is caused by tetracycline. When it comes to the uses of tetracycline, as I told you, broad spectrum antibiotics. Although tetracyclines are broad spectrum antibiotics, they should be employed only for those infections which are more selective and less toxic drugs are not available. Because nowadays we have so many other group of antibiotics which are less toxic and having more selective action than tetracycline. That's why clinical use of tetracycline have very much declined due to availability of fluoroquinolones and other various antimicrobial agents. So coming to the first use, that is empirical therapy. Tetracyclines are often employed when the nature and sensitivity of infective organism cannot be reasonably guessed. If you take an emergency case which is having high fever and suddenly came to the hospital and we don't know the exact reason and we are suspecting mixed infection, you can blindly give a try till you are going to wait for the culture and sensitivity report. As an empirical therapy, you can give tetracycline. However, they are not dependable in case of empirical treatment for serious and life-threatening infections. Of course, because nowadays we are having better drugs, we are going to give the newer drugs for empirical therapy. And they may be also be used for initial treatment of mixed infections, a combination of beta-lactam, that is for gram-positive organism, and a combination of aminoglycoside or third-generation cephalosporins or fluoroquinolones for gram-negative organism. For beta-lactam antibiotic, penicillin group of antibiotics for gram-positive coverage, aminoglycoside or cephalosporin or fluoroquinolone mainly for gram-negative coverage. So that's the mixed infection. And coming to the first choice of drugs, tetracyclines are the first choice of drugs in various venereal diseases which are caused by chlamydia, that is chlamydial non-specific urethritis or endocervicitis, lymphogranuloma venereum, granuloma inguinale, atypical pneumonia which is caused by mycoplasma pneumoniae, psittacosis, cholera. Tetracycline having adjuvant role. Adjuvant means supportive role. by reducing stool volume and limiting the duration of diet. Brucellosis. Tetracyclines are highly efficacious. It's a combination of therapy of doxycycline plus rifampicin for 6 weeks. Plague. Tetracyclines are highly effective in bubonic and pneumonic plague, and these are preferred for blind or mass treatment of suspected case during an epidemic. Though the streptomycin acts faster, it's not possible to give an injection. So that's why for blind or mass treatment, tetracyclines are preferred in case of a sudden epidemic. Relapsing fever, which is caused by Borrelia recurrentis, is going to respond with tetracyclines. Rickettsial infection, typhus, Rocky Mountain spotted fever, Q fever, they are going to respond dramatically. Chloramphenicol is an alternative for rickettsial infection, though tetracyclines are more preferred. Tetracyclines as second choice of drug. That means where you cannot use the first line drugs. For example, when the patient is having hypersensitivity reaction to the penicillin or ampicillin, you can use as a second choice of drug for tetanus, anthrax, actinomycosis, and licherial infection. And as an alternative to ceftriaxone, amoxicillin, azithromycin for gonorrhea, especially where the penicillin resistance non-penicillinase producing Neisseria gonorrhea, and also in patient allergic to penicillin, as I told you. An alternative to ceftriaxone for syphilic patient who is allergic to penicillin, and penicillin for leptospirosis. Doxycycline can be used as a 100 mg BD for 7 days. Azithromycin for pneumonia because of chlamydia pneumoniae as alternative to ceftriaxone, azithromycin for chancroid as an alternative to streptomycin for tularemia. Other situations where tetracycline may be used: the urinary tract infection in odd cases in which organisms have been found sensitive, community acquired pneumonia in case of amoebiasis, especially for chronic intestinal amoebiasis, as adjuvant to quinine or artesunate in chloroquine resistant falciparum malaria, and acne vulgaris, prolonged therapy with low doses may be useful. Chronic obstructive lung disease. Prophylactic use of tetracycline may reduce the frequent exacerbation. Tigecycline. Tigecycline is the newer one, belongs to new group that is glycyl cycline, which is active against most bacteria, which are developed resistant to the classical tetracycline, which is having the broadest spectrum of activity. Now, the tigecycline, of course, is a derivative of minocycline, where you are going to use tigecycline. No, you are not going to use blindly tigecycline for each and every infection. It has to be used as a reserve drug. Whenever the infection or the bacteria is not going to die with most of the antibacterial drugs, you have to go for tigecycline. It is having activity against most of the organisms, gram positive and gram negative, anaerobe, and MRSA, VRSA, methicillin resistant Staphylococcus aureus, vancomycin resistant Staphylococcus aureus, no, vancomycin resistant enterococci. That means it's a very powerful newer drug which can be used as a last weapon. So, what is the mechanism of action? As I told you in the part of development of resistance to the tetracycline, they are going to form efflux pumps. You are going to push out of the classroom. So here they are going to mainly affect because of tetracycline efflux group, which is unable to pump it out. The other one, it is going to form a ribosomal protection protein. You are going to close your ears. So these two most important mechanisms which are not going to affect cycling. So it is poorly observed from GIT. Of course, you have to give only slow IV infusion. As I told you, tigecycline is approved only for treatment of serious hospitalized patients of community acquired pneumonia, complicated skin and skin structure infections, complicated intra-abdominal infection by enterococci, anaerobes, MRSA, VRSA, enterobacteriaceae. That means it should be the last weapon. Coming to the adverse drug reactions of tigecycline, nausea, occasionally vomiting, epigastric distress. These are all routine things. There will be chance of superinfection. One of the important thing, it can cause pancreatitis. That's it about tetracycline. We will go to the next drug, that is chloramphenicol. Chloramphenical is initially obtained from Streptomyces venezuelae in 1947. Then after that they synthesized commercially. So coming to the mechanism of action, it is also going to inhibit the bacterial protein synthesis. It is specially attached to the 50S ribosome. As I told you, act at 30. A for aminoglycoside, T for tetracycline. So the other one is going to act on 50S, that is chloramphenicol. So that prevents the peptide bond formation. How it is going to attach the 50S ribosome near A site, acceptor site, and prevents peptide bond formation between newly attached amino acid and the nascent peptide chain. I will tell you, I will show you in the picture. And comes to the mechanism of action of chloramphenicol, as I already told you, there will be two sides. A site, that is acceptor site, P site, that is peptidyl site. Here, the amino acid tRNA will come and join to the A site, and by forming the peptidyl chain or the peptide bond, comes to the chloramphenicol. Chloramphenicol is going to inhibit peptide bond formation and transfer of peptide chain from P site to A site after binding to the 50S ribosome unit. Here you can see this is the 50S ribosome and this is the 30S ribosome. In the picture you can see the macrolide mechanism of action, and tetracycline also is going to inhibit the attachment of amino acid tRNA at A site, that is acceptor site. The antimicrobial spectrum, this is also a bacteriostatic drug which is going to inhibit the bacterial replication. That's what that means, they are going to decrease the growth of the bacteria. The number of the bacteria is going to be decreased. Bacteriostatic drug is not a bactericidal drug. It's not going to kill, but only in higher concentration it's shown as bactericidal effect. And some bacteria, that is Haemophilus influenza and Neisseria meningitis. So we all know this is a broad spectrum antibiotic which is active against nearly the same range of organisms as tetracycline. So it is active against Salmonella, more active than tetracyclines against Haemophilus influenza, Bordetella pertussis, Klebsiella, Neisseria meningitis, other anaerobes like Bacteroides fragilis, and it is less active against gram-positive cocci, spirochetes, certain enterobacteria, and chlamydia. And resistance, most bacteria are capable of developing the resistance to chloramphenicol, which is generally is going to emerge in graded manner, as like tetracycline. Being orally effective, broad spectrum, and very important, it is relatively cheap Chloramphenicol was extensively and often indiscriminately used, especially in our developing countries, resulting in high incidence of resistance among many gram-positive and gram-negative bacteria. So that means nowadays chloramphenicol is very rarely used because of development of resistance and there is high risk of some adverse drug reactions. I will tell you later. Coming to the pharmacokinetics, chloramphenicol is rapidly and completely absorbed after oral ingestion and 50 to 60% bound to plasma protein, and it is going to freely penetrate serous cavities and blood-brain barrier. That means can use in case of meningitis and all those. It crosses placenta and secreted in bile and milk. That means it is relatively contraindicated in pregnancy. Coming to the adverse drug reaction, the very important and very dangerous adverse effect of chloramphenicol is bone marrow suppression. Chloramphenicol is the most important cause of aplastic anemia, where it happens and it leads to suppress the bone marrow and the production of all the blood cells are going to be inhibited. That leads to a granulocytosis, thrombocytopenia, and pancytopenia. Here there are two varieties of bone marrow suppression. Is there two forms? That is one is non-dose related idiosyncratic reaction. The other one dose and duration of therapy related myelosuppression. The major and the big problem is non-dose related idiosyncratic reaction. That means if you give a single dose, and this is very rare, 1 in 40,000, unpredictable, but it is very serious, often fatal. Probably is a genetic basis and it runs in family. And aplastic anemia is the most common manifestation. A longer latent period of onset of bone marrow aplasia is associated with higher mortality. So, what is idiosyncratic reaction? The type of adverse drug reaction where we don't know if that reaction is going to occur to the particular patient. It is a genetic basis, right? And the second one, we can predict the dose and duration of therapy-related myelosuppression. A direct toxic effect. It is predictable and probably due to inhibition of mitochondrial enzyme synthesis in erythropoietic cells. It is often reversible. And of course, the other adverse drug reactions like hypersensitivity reaction, rashes, fever, atrophic glossitis, angioedema, and irritative effects like nausea, vomiting, diarrhea, pain on injection, and superinfection as like to tetracycline, but these are less common. And coming to the other important adverse drug reaction, that is gray baby syndrome. Yeah, this is the gray baby syndrome. Gray baby you can see in the picture. So what is this gray baby syndrome? It occurs when high doses, the more than 100 mg per kg body weight, were given prophylactically to the neonates, especially to the premature babies. So what happened? The baby stops feeding, vomiting, becomes hypotonic, hypothermic, abdomen is distended, respiration becomes irregular, and an ashen gray cyanosis is developed, followed by cardiovascular collapse and death. In lab finding, blood lactic acid levels was rise. So what is the reason for this gray baby syndrome? It occurs because of inability of the newborn to adequately metabolize and excrete chloramphenicol. So what happens? We all know. After taking any drug, it has to undergo metabolism and become inactive. Here, the chloramphenicol is going to be metabolized an enzyme called as glucuronyl transferase. So at higher concentration, chloramphenicol blocks electron transport in the liver, myocardium, skeletal muscle, resulting in above symptoms. Yeah, in premature infants, the level of glucuronide transferase will be very low. So that's why they are unable to metabolize chloramphenicol. So clinical uses of chloramphenicol, for systemic use, it is very rare because of fear of fatal toxicity, because of risk of serious bone marrow aplasia, as I told you. So that's why we have very rare uses, very rarely used nowadays. What are the various indications of chloramphenicol? What are the uses of chloramphenicol? The pyogenic infection, pyogenic meningitis. Of course, now we have the first line drugs as third generation cephalosporins plus with or without vancomycin as an empirical therapy. Once chloramphenicol is used, because it is as a second line drug for Haemophilus influenza and meningococcal meningitis, especially in young children and cephalosporin allergic patients, because of having excellent penetration, chloramphenicol having excellent penetration into the CSF. Coming to the anaerobic infections, which are caused by Bacteria fragilis and other like wound infection, intra-abdominal infection, pelvic abscess, and brain abscess. So responds well to the chloramphenicol. Mainly, we have very few drugs for anaerobic infection. For example, metronidazole. Metronidazole is the drug very commonly used for anaerobic infections, along with metronidazole, clindamycin, then chloramphenicol. So these are the more commonly used drugs for anaerobic infection. Then intraocular infection, chloramphenicol given systemically attains higher concentration in ocular fluid. So it is more preferred during endophthalmitis caused by sensitive bacteria. Enteric fever. Once in 1980s till 1980s, chloramphenicol was the first line of choice. But now the quinolones and cephalosporins are more commonly used. As a second choice of drug, as an alternative drug to the tetracycline for brucellosis and rickettsial infections, especially in younger children and pregnant women, where the tetracyclines are contraindicated. As an alternative to erythromycin for and for the treatment of improper, of course, uses of chloramphenicol is improper when safe drugs are available, very rarely used for urinary tract infection. Topically, so topically in conjunctivitis or external ear infection, chloramphenicol is highly effective. That's it. That's it about the class about broad spectrum antibiotics, that is tetracyclines and chloramphenicol. Thank you.